All right, this is the recap of CVD, coronary vascular disease. Remember that it's the most common type. Coronary arteriosclerosis is the most common type of CVD. It is an abnormal accumulation of liquid, fatty substance, and fibrous tissue in the lining of the arterial wall, which block and narrow our coronary arteries, which causes reduced blood flow and oxygen to the heart muscle, which means that our demand for oxygen is more than our demand for oxygen is more than we can supply. Here's a Khan Academy video that kind of breaks it down. If you would like to watch it, you don't have to. Some facts, which I didn't talk about in class, but they're kind of impressive. 610,000 people die of heart disease in the United States every year, so about 25% of the population, or 25% of the population that dies. It's the leading cause of death for both men and women. And about 735,000 Americans have a heart attack. So, interesting. This is the heart disease map from the CDC. If you look, the southeastern region is very, very red. So yeah, our South people love our fried diet. We have risk factors, non-modifiable and modifiable. So our non-modifiable are age, gender, ethnicity, and a family history. The family history is of a first-degree relative with a premature diagnosis, meaning they had heart disease under the age of 50. Because if you live long enough, you're going to get heart disease. Modifiable factors, diabetes, high blood pressure, smoking, certain drugs like cocaine, methamphetamines, caffeine, excessive alcohol use. Again, excessive alcohol use doesn't mean you can't have alcohol. It just means don't drink it excessively. Obesity, physical inactivity, and dyslipidemia. There's also an emerging body of evidence that's showing that there's some link between inflammation and cardiovascular disease, and that people with a BMI that is above 35 have 2 to 3 chances higher of getting coronary vascular disease when compared to somebody that has a normal BMI. Then you also have those metabolic abnormalities known as metabolic syndrome, and that is a significant risk factor with coronary artery disease. So you need 3 of the following: insulin-resistant, abdominal obesity, dyslipidemia, high blood pressure, increased CRP, and a prothrombotic state. High blood pressure, abdominal obesity, and dyslipidemia are like the leading 3 factors there. Signs and symptoms. Symptoms are dependent upon the amount of blood flow that is impeded to the heart muscle. Due to this obstruction, the heart is not adequately oxygenating and cardiac muscle death occurs, and this is called ischemia. Ischemia is pretty much irreversible. Angina pectoris is just another way of saying chest pain. Significant blood supply loss or obstruction can lead to MI, and heart damage due to the fact that we have this ischemia occurs, and that causes low cardiac output and leads to heart failure. So pretty much anybody that has an MI ends up having heart failure. The classic signs symptoms of cardiac cell death. So these are symptoms of the cardiac cells dying. The crushing chest pain, shortness of breath, fatigue, diaphoresis, nausea, vomiting. Please, please, please remember that the pain of an MI can be differentiated from stable angina by how persistent the pain is, despite rest and administration of nitroglycerin. So if rest fixes it, if nitroglycerin fixes it, you are stable. You have stable angina. But if you can't get comfortable, if rest doesn't fix it, if nitroglycerin isn't fixing it, then it possibly could be an MI. People that have an MI need narcotics. They need IV morphine to help with the pain. So that is your big difference between the 2. Women have non-specific symptoms, and elderly can have a silent CAD. So prevention, medical management, and nursing management. We need to control our cholesterol abnormalities, and medicines to treat them are on page 425 in your book, Managing Hypertension and Controlling Diabetes. I say let's manage hypertension and control diabetes so that we do not have to get put on these cholesterol medicines because they are horrible. So the first ones are the HMJ-CoA reductase inhibitors, also known as your statins. The big side effect of a statin is rhabdomyolysis, basically the body eating itself. So you're going to have some muscle aches, going to have elevated liver enzymes, going to have dark-colored urine. They also can cause elevated blood glucose. So with the diabetic population, if they're on a statin, and a lot of them are because they have cholesterol issues, they need to be aware that this can cause elevated blood sugar, and they might need to control their blood sugar even better than they should be. Absolute contraindications of pretty much any cholesterol medicine is liver. Nicotinic acid, side effects of nicotinic acid, flushing, elevated blood sugars, hepatotoxicity. Again, your absolute contraindications are liver disease and severe gout. Fibric acids, an example is fenofibrate. A big side effect is dyspepsia. It also has led to unexplained, non-related coronary heart disease deaths. Absolute contraindications, liver and kidney. Bile acid sequestrants, your example there is cholestyramine. They generally cause a lot of GI distress and constipation, so they should be given away from other medicines and with food to help, because they decrease the absorption of other drugs. You want to give them away from other drugs, and you want to give it with food. Don't give if your triglycerides are over 400 or you have this dis-beta lipoproteinemia. So cholesterol levels, you need to know them. Your low-density lipoprotein, your LDLs, those are your bad cholesterol. They need to be less than 130. So if they are more than 130, that is not good. Your HDLs, high-density lipoprotein, are your good cholesterol. So good is high, bad is low, right? In males, it should be better than 45. In females, it should be better than 55. And then our triglycerides. If you're a man, it should be anywhere between 40 and 160. And if you're a woman, it should be between 35 and 135. Oh, women just get the short end of the stick. So angina pectoris. There are 5 types, and I only focused on stable and unstable in class. And I meant to mention the other 3, but I forgot to. So intractable, refractory, that just means like you are having this crazy pain. It's it won't stop. That's what intractable is. It doesn't necessarily mean that you're having an MI, but it's not stable. Variant angina is basically spasms, and calcium channel blockers treat variant ischemia. And then silent ischemia is basically people that have all the markers of acute myocardial infarction, but they don't have any of the symptoms. So probably your elderly population. The patho of angina, again, generally caused by atherosclerotic disease. There's a blockage in your coronary artery. Your heart needs this huge amount of oxygen from the circulation, and it's not getting it. When your needs increase, and the blood flow should increase, but it doesn't. And then if you have a blockage, that flow is unable to increase, and ischemia results. Your risk factors are the same as coronary artery disease. And this is just another way to look at it. Basically, your coronary blood flow goes down, and it causes chest pain. Your O2 consumption goes up, your blood flow goes down, you're having chest pain. So mechanisms that decrease blood flow, so spasms, fixed stenosis, narrowing of the artery, and thrombosis, clots. Mechanisms that increase your oxygen consumption, your heart rate increases, your contractions are stronger, and your blood pressure increases. Another picture, just to kind of help give you a visual to what happens. Here is your artery, and it's getting plaque, and now it's got a lot of plaque, and blood flow can't get through very well, and then we're going to have ischemia. So signs and symptoms of this. It can radiate to the neck, jaw, shoulders. It can radiate to the upper arms. You can have tightness, heaviness, choking, or strangling. It's vice-like and persistent. Crushing in men. Diabetics, they might not feel such sharp pain. They might feel just a dull pain. Women are going to have atypical symptoms. But if it's stable angina, it's going to subside with rest or nitroglycerin administration. If it's not stable angina, it's not going to subside with nitroglycerin or rest, and then you're going to have the associated symptoms. Assessing angina, you're going to use PQRST. It's the same as old CART, pretty much. PQRST stands for position and provocation, quality and quantity, radiation and relief, severity, symptoms, and timing. So, does any certain position help it? Does anything make it worse? What does it feel like? How long have you had it? Does it go anywhere? Anything making it better? Anything making it worse? How often does it occur? How much has it affected your activities of daily living? What other kinds of symptoms are you having? That is assessing angina. The medical management objectives are to decrease the O2 demand of the heart muscle while increasing oxygen supply, and this is met via pharmacy and reperfusion. So your big difference between stable and unstable, again, exertional or stress-related with stable. Nitroglycerin or rest are going to relieve it. It lasts less than 15 minutes, and it's not generally associated with nausea, epigastric distress, dyspnea, anxiety, or diaphoresis. With a heart attack, it's going to last more than 15 minutes. It can last as long as 30 minutes or more, just depending on how long it takes you to fix the problem. It can occur without cause, and it's only relieved by opioids. You're going to have associated symptoms. Laboratory tests. So the big one is troponin. Diagnostic procedures, we have the EKG and the stress test, the thallium scan, and the heart cath. Heart cath, we are not going to talk about that in this class because that is a critical care type thing, but it is a diagnostic procedure that is used. I didn't talk about inotrope or chronotrope in class. I just want you to know what it is if you should ever come across it in your reading. Inotrope is talking about the force of contraction, and chronotrope is the change in heart rate. So like a beta blocker would be a negative chronotrope and a positive inotrope. Digoxin is a negative inotrope and a negative chronotrope. So just think about what that does, what the medicine does, and that will help you decide if it's inotrope, chronotropic, or both. But it's not overly important for me. Just want you to know what it is. Please, 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 please know your nitroglycerin education. Box 14.3, page 428 in your book. Please read it. Other things, beta blockers, we've talked about those. Calcium channel blockers. Important for variant angina. Antiplatelets. What is an antiplatelet? They increase your risk of bruising and bleeding. You want to use cautiously with a history of bleeding ulcers. They help keep your platelets from aggregating together. Aspirin and clopidogrel are examples. And then anticoagulants are generally used more for MI. We will talk about them next week because we are going to go deep into anticoagulants with DVTs, but not for MIs, or not for angina because we don't talk about MI.